So, welcome everyone. I'm Ross. I'm here with Eduardo and Phil, and we're going to be talking about shock interfaces. Um, this is pretty exciting because this is something new. This is admittedly something that Eduardo and I actually don't know a ton about, and we're excited to learn along with everyone. There is a link here for the Hospitalist Resuscitationist Conference in May 22nd and 23rd, 2025. Phil, myself, and Eduardo, we co-run the conference here, and shock interfaces are going to be a huge part of it, and a lot of the lectures and workshops are actually going to be centered around it. So if this is something that's interesting to you, definitely we'd love to have you. We also want to thank our sponsor for HCP rounds, Flowsonics Medical. If you don't know, they produce the wearable flow patch, which can actually interrogate the carotid and the jugular Doppler. What you're going to see with the shock interfaces is that you need a way to assess forward flow, but also the back pressure, especially on the right side. Many of us do venous congestion ultrasound or vexus, but one of the things I think is really cool about flow patch is it actually gives you the jugular Doppler, and the waveform of the jugular Doppler can be a surrogate for venous congestion. They've sponsored us kind of from the start of HCP round, so just thanks again to everyone at Flowsonics. We really appreciate the support. And then finally, this is actually something I'm working on. It's a project resub. If you're a clinical researcher, you're submitting papers to different journals. You've probably experienced the pain of having to format your paper for a journal after rejection. We're trying to automate this all so that you can just simply choose a journal, an article type, and your paper will automatically be reformatted. It works. If anyone's interested in checking it out, currently we have a bit of a discount for some of the early users here, but it's been a really fun project and something I appreciate it if anyone's interested in checking out. And with that, we're going to dive into the interfaces paradigm. So I'll just start off by saying that traditional resuscitation paradigms have really focused on kind of forward flow, optimizing cardiac output, stroke volume. But many of us, and probably many of the people on the webinar here, have realized that there's more to this. There's kind of the back pressure as well, or the congestion status, and that organ perfusion pressures are determined by both forward flow and pressure, but also back pressure. Now, admittedly, that's kind of where my sophistication on this kind of approach stops. And I don't regularly think about these different other interfaces, the macro to microcirculatory coupling, capillary to venous coupling. And so that's what we're here to learn with Dr. Phil Rola, creator of the Vexus score, resuscitationist, but also the now creator among some other people, Dr. Prager and other kind of clinicians, this interfaces paradigm that we're really excited to learn about. Phil, thanks for joining us, and Eduardo, always nice to hang out.
Yeah, it's always great to be here, Ross. Thank you, Phil. It's always an honor to be part of of, of your creative and very elaborate physiological understandings. Thank you for sharing this with us today.
First of all, thanks a lot, guys, for having me. It's always fun to hang out. It always sparks a lot of interesting thoughts and discussions and further things. But I'm going to start by correcting you. You guys know all of this stuff. It is nothing new. It's just a matter of putting it together. And I think that most of the H&R family, most of the people who are legit resuscitationists, do all these things, know all these things. It's just, to me, it's an approach that if you're starting in hemodynamics, or if you're if you're not yet at that sort of expert level, then I think it's easier to start off realizing that this is a circuit, the circulation, it goes around, and there's different interfaces in the circulation, and it's key to understanding that if you're only focused on one, and like Ross just said earlier, that sort of entry level resuscitation is, well, what's my MAP? And then the next level is what's my MAP, and maybe I'm going to think of looking at my venous congestion a little bit. But ultimately, why are we resuscitating, right? What we want to resuscitate is the microcirculation. Ultimately, the rest is just tools and parameters that we tweak in order to optimize the microcirculation. That's really what it is. And I think that if you're not looking at all these interfaces, then you may be focusing on something that either is okay or you're not getting much improvement, and you may be neglecting some other areas that are really hampering your microcirculatory improvement. So that's why we kind of got together, a bunch of people and said, listen, what are the critical hemodynamic interfaces? And when I say interfaces, when one type of circulation is switching to another, let's say, the ones that's the most commonly known and recognized is your LV to arterial, or your RV to pulmonary arterial. Those are kind of commonly known. But anytime you have a change from an actual pump to a more of a receiving, and then afterwards, so let's just go through quickly those four interfaces, and I think that'll give people an idea. So if we start, not to be too cardiocentric, but if we start from the LV, we chose that as interface one, but really it doesn't really matter. So your LV to arterial tree, that's your first interface. That's the first where the energy is transmitted from the pump itself into the arterial tree. Now, the second one is the transfer from the arterial tree through the distal arterioles into the capillary network. That's interface two. Interface three is the next shift over when you're going from the capillaries into the venules. And that's that's something that really, like Ross said, the recent interest in congestion has started to bring out. And then finally, what may be the engine behind congestion is, how is my RV interacting with my PA? That's interface four. Now, admittedly, there was a couple more interfaces that we considered including. We could have said great veins to RA. We could have said pulmonary veins to left atrium. But ultimately, the idea behind the four interfaces is that, and these can be individually disturbed without disturbing the others and resulting in troubles in terms of your circulation. So and then it would have made the system a little too complex. We didn't feel that it added too many things where in terms of shock. Now, if you're talking about congestion, heart failure, etc., these other interfaces, especially the pulmonary venous to left atrium, are exceedingly important. But here we're talking about shock approach and management. So it becomes less. So there you go. That's kind of the four interfaces. And then we can talk about briefly like how to assess each one. But does that make sense to you guys? Yeah, I know you guys know all this.
Yeah, sure. I just want to say, I mean, we do this. We didn't call it interfaces, and we don't necessarily have this order of going from 1, 2, 3, 4. I don't think you have it in the specific order as well. But anytime, and I'm speaking from the point of view of a nephrologist. So this is advanced nephrology, I must admit, but whenever I see a patient, I get consulted for oliguria, and I want to figure out, well, I already figured out the kidneys are fine and it's a hemodynamic problem. Then I will go through these four and try to think about the renal capillaries, the left-sided heart function, and whether it's pumping blood correctly through the arteries to the kidneys, and then the back pressure to the kidneys, and then of course whether my RV is doing okay. And then I do all this, and even if I'm not assessing shock per se, but rather acute kidney injury or hemodynamic acute kidney injury, which is again a good overview of all the things that could be going wrong hemodynamically. I did not call them interfaces, but I think I agree with you that this is something we've been doing. And then people who are interested in hemodynamics should know this from the get-go.
I totally agree as well. And I guess one question I have for you, Phil, is each one of these interfaces has coupling. Coupling is something that is increasingly being talked about in the literature, but are you able to just kind of give us a broad overview of coupling, maybe at a broad sense, and then maybe go into each of these interfaces and what actually coupling or uncoupling looks like for each of these interfaces?
Sure. Now, admittedly, we use the concept of coupling. It originates from engineering and computer engineering as well. So it's a bit of a loose, analogy, but I think it fits reasonably well. So coupling is that, if you've got two different systems that are meshing together, there's usually a certain range of each side's parameters, if you will, for the system to function efficiently and well. For instance, I think the easiest one to go through, is the LV to arterial. So you
And
can
Phil,
easily imagine. Yeah.
Phil, even before you go into there, one analogy that I heard just kind of in generally from the engineering side of things, which I love, is like the bicycle. Because if you're cycling and you're in
Yeah.
first gear and you're trying to go up the hill, yeah, your pedals are going really quick, but you're not going very fast. But similarly, if you're in 14th gear, you can barely move the pedals and the system's not really efficient. So there's some sort of optimal kind of ratio between how hard you're pedaling and what gear you're in that makes it easiest for you to go up the hill. And so either extreme is not going to be working. Is that kind of how you think of it, just coupling in
Yeah.
general?
That's a fantastic analogy. Yeah, you probably, that medium hill, you're going to need to be somewhere in the middle. And exactly. And you can look at the hill as being your arterial elastance, and then you can look at, your legs as being sort of the end systolic elastance, which are terms that are, formally used. But to be honest, we don't necessarily have to go to that sort of, bench level at each one of the interfaces. It's more important to just understand the concepts. From the LV, you can understand that, look, if the arterial squeeze, the vasoconstriction is really high, then you're going to have a good, function to match it, and if you have a perfectly normal heart, you can overcome almost anything, a perfectly normal RV. But, there's some point, at least a theoretical point, where you're going to start to struggle because of that increased, our resistance. At the other end, let's say that, you're very vasodilated. So you might be squeezing well, but your arterial elastance is so low that, you're not being able to generate sufficient systolic and diastolic pressures because everything's so dilated. That's your distal side or your arterial side being too vasodilated. So basically, you have to make sure that those two systems are within a certain range to make, efficient transfer of energy across.
So what does it actually look like? Is this like you're getting cardiac output, stroke volumes? How do we act for, let's take interface one. How does that look like in reality when you're assessing whether or not it's coupled, what the optimal coupling is, and how do we know?
So I think optimal is remains to be seen. I think today there isn't enough evidence. I mean, to be. I was just actually listening to Scott talk about cardiac arrest a few days ago, and saying how, what, the there's, and that tends to be, I think, for anything that is still a very growing field, you have evidence at the very base, but as you go up higher and higher levels of complexity and sort of sophistication, the actual evidence becomes less and less. But we do know that, in extremes of uncoupling, let's take the first interface. Really, the quick and dirty way to look at the coupling is to look at your EF. A lot of people equate that to actually contractility, which, it is to some degree, but you can't forget it's a load dependent parameter. So, it doesn't necessarily reflect your inherent contractility. It's just that it does reflect coupling. It reflects that, hey, if I've got a very high EF, well, that tells me that, my LV has no problem dealing with a current afterload. But if that afterload is low, then, we know we're getting out the volume that we want now. But once we perhaps increase that afterload, we have to reassess and see if we're still hanging on and doing reasonably. If we increase the afterload to a reasonable level, but then we are no longer generating a good ejection fraction or a good stroke volume, then we have shown that actually the system at this level of arterial resistance or elastance is no longer coupled. So if you have a low EF, you already know that you're uncoupled. Now, 40, 45 may be okay. That's why it becomes a little bit difficult to give specific numbers. But if you have a patient in shock, you have a certain blood pressure that is low-ish, and you have a low ejection fraction, there's some degree of uncoupling there, and probably the answer isn't fluids.
Hmm. I was just going to ask, in that situation where you have a patient in distributive shock, they have a low EF, maybe like 40, 45, that kind of borderline zone, but their stroke volume is preserved. Is
Mm-hmm.
that now the tiebreaker between that patient probably is still coupled versus the patient whose stroke volume is low is uncoupled, or how does that integrate?
Yeah, I mean, to me, that would intuitively come out as well, you know what, they're probably on that lower edge, but they're hanging in and their coupling is reasonable. And if their forward flow, their stroke volume is okay, then I'm probably okay with that. Still have to look at the whole circuit, but I'm probably okay with that. And that's a really important point that you bring up there, is looking at your stroke volume, whether you're using VTI, carotid flow time, whatever it may be. You have to look at your actual stroke volume. Looking at your EF, just someone, for instance, tells me, oh, the squeeze was good, and then sort of dismissing the cardiac output as an issue can be a pretty consequential mistake, because you may have someone whose EF is 75-80%, which is encouraging for coupling, but their VTI or their stroke volume may be terrible and they need something. Usually in this case, they would need some fluid, but again, got to look at all the interfaces.
Yeah, so I mean, I know there are more advanced ways to assess for ventricular arterial coupling, and then this of course can be done with invasive measurements, but then there's also echo ways to measure, your systolic ejection times and all this. Is this something you regularly do at your bedside? Do you actually calculate the numbers of the arterial elastance and ventricular elastance and do this division to get your coupling? Or is this something you just glance, like a rule of thumb, look at EF, look at mean arterial blood pressure, and kind of take it from there?
Yeah, I mean, I toyed around with that like a year ago or so, and spent a few weeks doing that sort of regularly. I don't think that for the clinician bedside really brings a lot. I think you can get it from your BP or EF, your VTI, et cetera, et cetera. But I think obviously if we're starting to look at finding prognostic measures, assessing for prognosis, assessing post-intervention. I think there is one thing that I think this is a subject that's sort of at that stratospheric level of stuff of beyond the bleeding edge, but looking at some of these pre-ejection versus ejection times, I think is an interesting thing, and I suspect there's going to be something with that somewhere down the line. But here and that's one of the things about the interfaces that I think is important to get out, is that we're not saying there's one way to do it. I think there's many different ways at different levels of sophistication, equipment availability, et cetera, to look at all these different interfaces. So, essentially, even if you're just armed with, your blood pressure cuff and your stethoscope, you can still, cover a fair bit of this.
That's very interesting. I mean, moving on, because I find this a little bit more challenging, how to kind of think of interface 2 and how to assess it, given it's a capillary level. How do you go around thinking about what's interface 2 and how to assess this at the bedside?
Yeah, admittedly, this is very tough in terms of, it's not so much that it's difficult, it's just that we don't have, all the necessary tools yet. I think they're around the corner. I mean, the technology has been around, it exists, but the in vivo microscopy, there's actually, a whole lot of actually well-described microcirculatory flow parameters. A lot of the work from Jan Inchi, has established this, and I think is actually the cornerstone for showing the importance of looking at, these different interfaces, but it's just not yet readily available. I think, fortunately, we have Glenn Hernandez and his team, Eduardo Catana and all, to thank for bringing to the forefront capillary refill time, which is currently that's really what we have, and I think it's been made fairly clear that, and modeling indices and things like that to show that, hey, if the skin isn't doing well, there's a reasonable chance that the rest of the body isn't doing that great, or at least it's on the edge of not doing that great. So I think right now it's really looking at capillary refill time is our, only bedside way to really look at that.
And Phil, I have a question about that. We talk a lot about the concept of hemodynamic coherence. And
Yeah.
for those of you who aren't as familiar, hemodynamic coherence talks about the fact that often early in resuscitation, when somebody has abnormal microcirculatory surrogates, for example, cap refill time, if you give them a fluid bolus or an inotrope or a vasopressor to address whatever physiologic derangement, they have improvement in their microcirculation. However, later in disease courses, due to a combination of local factors, tissue edema, congestion, patients become hemodynamically incoherent. And what that means is that despite improving systemic hemodynamics, we don't see improvement at the tissue level. How do you kind of separate in your mind macro to microcirculatory coupling versus hemodynamic coherence? They're clearly related, but just I'm wondering how you conceptualize that.
Yeah, I mean, I think that really, if you're there's almost sort of two categories. There's that sort of septic one. There's that really micro hemodynamic, extensive pathology that no matter what you do to the macro, you're not going to fix. You just have to ride the storm through, and hopefully, things will recanalize and improve down the road. That's sort of like I don't know if we separate them into a type B or something like that. I consider that for many people using the very sort of ground level resuscitation, they might see incoherence, but to me, it's due to interface uncoupling, which can be fixed by proper interface assessment.
Mm.
So let's take an example. You have this patient who's a septic shock. They've got their oh, now you get the blood pressure up. Let's say their cap refill at the beginning was, this is someone doing ultra basic resus. They just start them on levo for septic shock. They got a few liters of fluid. And then their BP is now up to, it started off at say an MAP of 45, and then they get it up to 65, but the cap refill has not improved. The cap refill, if anything, they've gotten more modeled, et cetera, et cetera. So, in that short time. But if you put the probe on, you might see that what they actually did is, with the increased afterload, they've uncoupled interface one, so the stroke volume actually dropped. The VTI actually dropped. So that, to me, is not incoherent. It's incoherent if you look at it at that ultra basic level, but you have macro indices, you have interface dysfunction uncoupling that you've caused by your therapy. And if you appropriately manage the rest, you should be able to get back to having coherence at the microcirculatory level. Same thing, if
Mm.
you fluid overloaded your patient, your CVP is now 18, your forward flow indices may be okay, but your macro is uncoupled. So now you also have a form of incoherence. So perhaps we need almost two types of incoherences, one interface related, the other one purely micro, capillary dysfunction.
Yeah, it's like saying a patient has refractory shock without doing an echo.
There you
They're
go.
refractory to levofed and high doses of phenylephrine, but when you actually look and there's a pericardial effusion and tamponade, they're not refractory to draining that or whatever else. So that really resonates. Thanks.
Yeah, we're getting some questions regarding this interface, and I think they're interesting. One regarding the use of the delta or the venous arterial CO2 gap, which I
Mm.
think this has been described by the group of our friend Glenn Hernandez, and using this to assess for microcirculatory uncoupling. I know, of course, this was described in cardiogenic shock, but what about these patients whose cardiac output is normal or even increased and delta CO2 gap is still increasing? Is this a sign of microcirculatory uncoupling? Do you use this clinically, or is this just noise for you?
Um, I don't use it at that level, but I use that. I think that's really important to, and I think that's probably a concept that is going to be coming out is, when can you declare that you're satisfied with your resus? Because things might still look pretty ugly, lactates up, this, that, but when are you satisfied with your interface management? And I think that's where these sort of global tools like that, come in handy.
And
Whether it's looking at
can
the
you just
gap,
ex
looking at SCVO2.
can you just
Yeah.
explain this at like a basic level for those of us who aren't as familiar with this kind of what does the gap signify, what's normal, and how might it trend if you're under resuscitated versus if your interfaces are okay?
Sure, sure. So, you're normally your arterial venous CO2 gap, and ideally you want to look at that centrally. So from a central or a mixed venous gas, your gap between your arterial and venous CO2 should be 6 or less. That means that you're giving enough blood flow to your tissues to manage your CO2 production. So when that comes up high, then it kind of points to the fact that you've got, you're just supply and demand. You're just not supplying enough flow to wash out your CO2. If you're below 6, then presumably you're doing a reasonable job at providing enough tissue perfusion to your tissues.
Perfect. Thank you.
Great.
Yeah,
Sure. I just wanted to
hope
add
that
just
answers.
one more question Somebody's asking whether besides the capillary refill time, if just the subjective feeling of skin temperature at different sites, does this give you a synonymous or maybe equivalent information? Do you use this more than maybe just looking at capillary refill, or is capillary refill still the gold standard?
Yeah, I mean, I think capillary fill is kind of like, something that we have numbers for, but I definitely use more than that. I mean, every now and then you get people whose, fingertips are just really cold, but then the rest of them is really quite warm. And sometimes I'll use forehead. I'll definitely do a global assessment. I tend to avoid really basing, my assessment of their, because of their sort of vascular resistance, arterial or tone on truncal, because I think that just remains much. But I definitely use, and I think we have good data on modeling of the knees, using the whole hands, using, I think I do extend it more than that clinically at the bedside, but, it becomes a little bit hard to measure those things. I do use cap refill as the one that, at least in communicating or getting information from my fellows, residents, et cetera, I use the most as from a communication standpoint.
Yeah, that's great. That's great. I think we've covered some of whatever we can do with capillary refill and microcirculation, because this is really a research avid area where we don't really have all the answers right now. But I think one of the interfaces that we are now able to assess at the bedside, which way more confidence than we used to maybe 5 years ago, is interface 3, which I think it should be our favorite, especially, Ross and I, we know interface 3 is one of our contributions to medicine. And I would like to hear your thoughts, Phil, on how do you, what is interface 3 and how do you assess this at the bedside?
And Phil, can I just add even one more point to that? Can you just explain a little bit about what mean systemic filling pressure is, and kind of how that integrates as well? Because it's something that we talk about a lot, but it's not in the common medical vernacular.
Sure, absolutely. I think it's a, so basically mean stomach filling pressure is the pressure that results if the circulation is arrested and gets time to equilibrate. And if we think about it, that really is the driving pressure for venous return. And essentially the heart's job is to create as low a CVP as possible in order to facilitate that venous return. So basically here in this interface 3, we're dealing with the interaction between the capillary and the mean systemic filling pressure, or close to it, at the level of the venules, where the capillaries have no choice but to drain. And, I know there's a, that waterfall concept is true, it exists, et cetera, but it's important to realize that it exists at the proximal part of the capillaries. But then once the flow has gone over the waterfall, well, it still has to go and, get to the final destination, get to the ocean, if you will, or whatnot. So you're still going to have to deal with whatever back pressure you have. And that, as you guys are hinting to, is where tools such as including vexus have come in. Because basically, and it's important to look at venous congestion from an organ standpoint. It's not just the fact that the veins are distended, the pressures are high, because a lot of people think about that. And in fact, people think as CVP as a preload, whereas when you're thinking about it from a venous congestion standpoint, it's an organ afterload, and that the organs don't enjoy. And it's been well shown. You have those we often quote that Winter experiment in the 30s, looking at creating venous stenoses at the kidneys, and how the kidneys didn't like that. If anything, they like that increase in venous pressure worse. They liked it even less than they did a drop in arterial blood pressure. So anyway, so that's it. That's what, and essentially also, if you want to split the interfaces, 1 and 2 to have, clear links together, 2 and 3 do, and 3 and 4 clearly do. Now, usually you get interface 3 uncoupling or dysfunction because you have an interface 4 trouble as well. But you can also get it, and the reason we separated them is that you can just get overzealous fluid administration, and you may still maintain a reasonable, RV to PA relationship, but you've just poured in so much fluid that your mean systemic filling pressure is up, and you're sludging the capillaries. And again, I think it was Valinga who had a nice paper on that, essentially dichotomizing to some degree. I'm not a fan of dichotomy, but I think for the purpose of conceptualizing things, a CVP above 12 really impaired microcirculatory flow, which is important because if you remember, that it wasn't that long ago that, the guidelines included 212 and more than 12 if you were ventilated. And that just kind of shows how people were still thinking very much in terms of forward flow and preload, and really not paying much attention to the venous and the organ afterload that venous congestion results in.
Yeah, it makes sense.
So tools to
Can I just hop in there for one question? If you have uncoupling of interface 3, will this always manifest on organ level Dopplers of the hepatic vein, portal vein, or intrarenal vein? Or are there patients that have uncoupling capillary level congestion but normal intrarenal Dopplers? In your experience, but also kind of theoretically.
That's a good question. I mean, one thing that we do see is like unbelievable adaptation sometimes of people who have clearly have venous congestion. And either they're like sometimes the Dopplers are not so markedly abnormal. So is that because they've developed, amazing, lymphatic collaterals to prevent the actual organ congestion? Maybe it is. I'm not sure I can answer that. But that would really be in the patients who have really chronic conditions. You see these, severe valvular pathologies, and people are like 90 years old who have these incredibly abnormal hearts and vascular systems, and yet their tissues are not so bad. They don't have so much edema. Their renal function's okay. And there's some modulation, I think, of that venous Doppler signal, but you can't have a completely normal, venous Doppler signal with terrible interface 4 dysfunction.
Makes sense there.
I lost my train of thought there, but let's keep going.
Sounds good. I guess then moving on to interface 4, and I know that actually, Eduardo, you had some comments on kind of pulmonary arterial elastance based on your own kind of research and clinical experience. Maybe to start us off, like what is pulmonary arterial elastance, and how does, because that's not something that we really think of, at least I don't think of regularly in my own kind of clinical practice.
I think, well, we need just to think about, what's your basic aortic elastance, and then that's the impedance to flow that the aorta will resist. And this is mediated by two things, right? So your systemic vascular resistance and your arterial rigidity, which then one you can modulate with drugs, and the other one is just mainly a result of aging and calcification and, just your atherosclerosis or arteriolosclerosis, which you cannot really do much about. Now, in the pulmonary arterial side, this really does not happen. I mean, your pulse pressure, your systemic pulse pressure increases with age because of this arterial stiffening with age, but really your pulmonary pulse pressure doesn't really increase with age, as you don't really get that much calcification and stiffness of the pulmonary artery. And so you would think the arterial elastance of the pulmonary artery is really just due to pulmonary vascular resistance. When this is really high, then your elastance is high as well. And then you might be tempted to treat all patients with high pulmonary arterial elastance with pulmonary vasodilators. But what I've found in our clinical practice, and seeing a lot of patients with pulmonary hypertension, and this has been well documented, been well published, is that yes, there is another factor that will influence your pulmonary artery pulse pressure. It means you can have a rigid pulmonary artery independent of your pulmonary artery vascular resistance. And that's your pulmonary arterial compliance. If you stretch the walls of a pulmonary artery, you will reach a point where your RV is pumping into an already stretched pulmonary artery, and you cannot just, overstretch it anymore, and it will act as a very rigid vessel. And this happens in severe left-sided heart failure. And so this will be a left-sided heart failure problem where a very increased in left ventricular and diastolic pressure. And so, you know, blood will just accumulate in the pulmonary artery. It will cause wall distension, and your pulmonary artery itself will become very rigid, and you will have a very high pulse pressure on your pulmonary arterial, on your pulmonary artery curve. And this will increase pulmonary arterial elastance. And this might cause some issues in interpreting which of the two interfaces is really affected. Is it interface 1 or is it interface 4? And because, of course, this is, as I've already told you, this is a left-sided heart problem, but this will dilate your pulmonary artery, you know, the pulmonary artery will become dilated and the elastance will go up, the compliance will go down, and it will be harder for your RV to pump against this already distended pulmonary artery. And some people call this combined precapillary and postcapillary pulmonary hypertension. And if you do a invasive hemodynamic measurements, because of the way we calculate pulmonary vascular resistance, you will think your pulmonary vascular resistance are really high, and you might be tempted to give pulmonary vasodilators. But if your LV is failing and if your left ventricular and diastolic pressure is really high, pulmonary vasodilators have never been shown to really improve any outcomes in this scenario. So I would just be very careful of thinking, why is my pulmonary arterial elastance high? Are there any signs that this could still be a left-sided heart problem? And then might I do anything else to decongest the left ventricle before I think of giving pulmonary vasodilators to this congested patient? And, you know, this can go from improving diuresis, just giving systemic vasodilators to improve coupling in the interface 1. But this can also include some left ventricular assisting devices where this have been shown to decrease pulmonary vascular resistance, even in patients with advanced heart failure or heart transplant candidates. And you see, you didn't do anything to the pulmonary vasculature. You used an LV assisting device, and then your pulmonary vascular resistance just magically goes down. Some people have confused this and say this is a vasoconstrictive reflex from the LV to the pulmonary artery. This is no reflex. This is just a matter of a stiff pulmonary artery because of stretching, because of fluid overload in the artery, secondary to left ventricular and diastolic pressure increase. So, you know, sometimes it's hard to differentiate between a pure left-sided heart problem or is there really a pulmonary vascular disease present. And just think, if there is a left-sided heart problem, just do anything to lower your left ventricular and diastolic filling pressure before your pulmonary artery or your pulmonary vascular vasodilators. I don't know if I've made myself clear, or if that's something you would agree, Phil.
Yeah, I completely agree. I mean, that's always the you know, I remember Corbin talking about this years ago, the difference between pre and post. And that brings up an interesting question: is how long has the left-sided failure been going on? Because essentially your pulmonary circulation is super compliant, and even though they developed that pulmonary hypertension, like you mentioned, it's because that system has just reached its limitation in terms of what it can dilate. It's tried to dilate all this time, unlike someone with primary pulmonary hypertension or PE or something like that, where there is actually some vasoconstriction, or even atelectasis pneumonia, where you have some pre-capillary vasoconstriction. And so what would be interesting to know is, if it's been going on for a long time now, you may have now started to have remodeling, and now you've got post and pre. So it's an interesting thing to try and figure out at the bedside if your vasodilator will help. Using notching, maybe using RVOT Doppler in the presence of notching may point you more to a pre-cap. But certainly, if I look at an RVOT Doppler envelope, and I know we're going a little bit over your basic interface stuff here, and I see no notching, I don't think pulmonary vasodilator therapy will help at all. Now, is there cases where in the presence of notching, you may still not get help? Definitely, I'm sure there is. I'm just not sure what other further way to differentiate the phenotype the patients further than that. But that's super interesting.
Yeah. No, I wanted to raise up one more case that I've seen where this becomes really challenging. It's the patient who has chronic diastolic dysfunction and elevated left ventricular end diastolic pressure. Their RV is failing as a result of it, and they have signs of pulmonary hypertension. Because in these patients, it can be like the LV systolic failure when the EF is 20%. Like we often, I think, will decongest and really try to optimize volume. But sometimes I find in these preserved ejection fraction patients, it's particularly challenging to figure out the chicken and the egg here. Do you guys have any tips for that? Like, what one of the questions in the chat was, what non-invasive parameters are you using to estimate LVEDP? For myself, it's B lines, E over E prime. Anything else that you guys are finding particularly useful?
I think the first thing that it's really a low hanging fruit is just your left atrial size on your echo report that you may or may not have. And I think a lot of times, if people just get used to reading the conclusion, that's often overlooked, even by some of the cardiologists writing up the reports. Oops, that left atrium is like 6 centimeters, but they only say, oh, mild diastolic dysfunction. So it kind of goes under the radar. But to me, that's the lowest hanging fruit that might be available to people who don't even do echo, not able to do E
Mm,
prime and things like that. Yeah, but otherwise, yeah, B lines, chest X-ray.
yeah. I remember Rob Chen talked about the left atrial volume as like the upgrade to your echo. I think that was
Yep.
HR 2018, the first time kind of I met Rob. So yeah, that's awesome.
And I think that's one of the important things to just bring out is that all these interfaces, you can look at them like with, you can at least get a glimpse of them with zero technology. It's not as it's all, of course, as you go up along the chain of sophistication, you'll get more precise and possibly more useful and be able to trend the impact of your interventions. But even if you approach a patient with just a blood pressure cuff and a stethoscope and your eyes and hands, you can still get a good feel. And if you know interface one, if the patient's warm, their pulse pressure is okay, it's probably okay. If their cap refill time is okay, then your interface two is probably okay. If your JVP is not severely elevated, you probably three and four are okay. And you can get into really looking at your JVP waves and trying to figure out if you have accelerated descents and or blunted Y descent. It's not impossible to do, but you could still get a pretty good idea. And if I can just take like a couple minutes to bring out, I think what I think are the two easily trapped scenarios. I think we briefly mentioned earlier the ones where you're driving up the MAP, everyone's happy, but the cap refill time's increasing. That's not good. If you're not consciously going to assess your interfaces, you could run into trouble. And then sadly, people say, well, they patient is not doing poorly despite adequate resuscitation. And then the other patient is the patient who is getting either a protocol mandated or well-intentioned, generous fluid resuscitation, where you're just going to, uncouple interface three and possibly four, and then your forward flow indices may be okay, but your microcirculation is going down. And if you look at your patient with a high JVP, a high CVP, an elevated vexus score, a pulsatile femoral vein, a discontinuous flow on your carotid, on your jugular, on your flow patch, then all these things are pointing to the fact that you've over fluid resuscitated, and your interfaces are no longer congruently helping your microcirculation. So I think those are two patient groups that as low hanging fruit you can avoid by even a cursory look at these interfaces.
Yeah, wonderful. I think that that probably covers the interface paradigm from the from kind of the broad overview. There's a bunch of questions here. I don't know if we want to kind of tackle some of these. Um, Eduardo, you've been kind of keeping an eye on it. They're great questions, and obviously this is such an interesting and challenging topic that it's generated a lot of discussion. Um, yeah, were there any, Eduardo, that you wanted to touch on quickly?
Yeah, I've answered some of them already, but there's still a lot of them that are showing here live. I think one that's good for now that we've covered all four interfaces, and I think this problem doesn't is not included in this paradigm, is what happens to these patients, which I don't think they're frequent, but certainly we've all seen them. Who have signs of fluid overload. They're edematous. They have fluids in all third spaces, but they are actually like low VTI, low preload, no congestion, and some would call them intravascularly dry. Is this not covered, I think, in this interface paradigm, and or is it? Maybe I'm just missing the point, but I think this is the question that Sergio is asking is which interface looks at this volume overload on intravascular depletion. I think no
Yeah.
interface is looking at this, but I would ask the question to you, Phil.
Yeah. So there's a couple of sort of in the paper that's submitted and under review, there's a couple of things that we mentioned. First of all, like there's no specific, I mean, if you break it down, mechanical obstruction like attention pneumo tamponade will, uncouple several things, but there's no point going through your interfaces. You have to fix the quickly reversible problem. So this is kind of assuming a relatively, open circuit. Now, interface one will definitely cover that because interface one includes having a low VTI. It's not so much a coupling issue because hypovolemia and low preload doesn't result in uncoupling per se, But in interface one, we also describe the need to do a VTI to measure your stroke volume in some way, shape, or form. So if you have low, so then the issue of the extravascular business is kind of a separate issue, like how you're going to manage that, whether it's a leak and you're going to hope that steroids, time, antibiotics, using removing evil humors, or going down to the mean by plasma exchange, etc. There could be a bunch of things that may be done for the leaky problem, but from a circulatory standpoint, if you have a low preload and a low VTI, well, in that case, let's just look at that one. Your interface 3 is going to be fine. Your interface 4 is going to be fine unless there's a severe, primary cardiac problem. What you're going to see at interface 1 is you're going to see, likely a normal coupling with small volumes, small stroke volumes, low VTI, low carotid flow time. And you're probably going to have a prolonged, disturbed interface 2 with a prolonged capillary refill time. So that syndrome kind of encompasses like overlapping issues of fluid tolerance from a soft tissue point of view, and circulatory troubles looking at interface hemodynamics.
Yeah, I agree. There's an interesting question here regarding interface 4, and they say when you do I would assume your RVOT Doppler and look for notching. How do you decide what the treatment should be when you see this notching? And I might just add a little experience I've had, and I see a lot of patients with end-stage kidney disease and a very high flow fistula that have this notching. And when I've done this invasive hemodynamic assessments, these are all left-sided heart failure with a high flow fistula. And I've come to think this is just the notching is due to a severely dilated pulmonary artery with decreased elastance. And as in some patients, I've just ligated the AV fistula, and this would allow me to decrease dry weight by doing ultrafiltration. And the notching goes away. And so I did not give any pulmonary vasodilators. The patient does not have a primary pulmonary vascular disease such as lupus or scleroderma or whatever, but the notching went away just by decreasing the volume of the LV. And so sometimes this does not mean there's a primary pulmonary vascular disease, but I think that should be our job. I mean, sometimes the treatment should be thrombolysis, right? So or invasive thrombectomy. And so I'll let you answer, Rola. How do you assess? How do you address a patient with shock that has notching on your RVOT Doppler?
I mean, clearly, what you have to rule out, because it'll be reversible, is PE. That would be the most important thing to rule out. So that patient's probably going to have to go to to angioscan unless I'm seeing things floating around. Or if the patient is in extremis, and I'm going to have to just make a call and lyse them there and then. But otherwise, yeah, that's super interesting. I think you're absolutely right. I think the notching, I think the papers that describe notching come from the stable pulmonary hypertension patients. I think, in resuscitation, we still don't know what that gives us. When I see the notching, it tells me that there's, I think if what will be interesting to see is if we have notching and, let's say a increased left atrial size or whatever parameters show increased left atrial pressures, then obviously the notching becomes less significant. So I think in the presence of notching and the absence of clear LV dysfunction, I think it's probably going to be worth, if there is uncoupling. If there's no uncoupling of our interface 4, which is sometimes happens because it's a chronic situation has been compensated, et cetera, then I would often try, either inodilators or inhaled, depending on how everything else is doing.
Yeah. Well, I think, I mean, that was an incredible discussion. Thanks so much for joining us, Phil. I don't know if you had any last remarks here about kind of the future of the interfaces, where people can learn more, anything like that before we wrap up.
Sure. I mean, I think it's in terms of learners. I find it, I have all my residents and fellows, come and discuss hemodynamic related cases with me using the interfaces. Because sometimes in the past you have someone will come and talk about someone who's unstable and say, well, the squeeze is good. The squeeze is good, and their MAP is so and so. I say, well, okay, well, what about the cap refill time? Oh, I didn't look, or let's go back and look. What about the CVP or the GVP or vexus or something? So I nowadays, like, after a few weeks, and they, the fellows will come back, say, okay, interface 1 is this, VTI was this, interface 2 is cap refill time is so and so, interface 3 if it was vexus 0, interface 4, TAPC is fine, and at least everything's been looked at. There's no like major issue that's been overlooked. So I think from a learning and supervising standpoint, I think that's really useful, and I think it's kind of, and we purposely left it vague that you don't have to do your interface assessment in one specific way, but hopefully some people with resources and teams can use some of this. I mean, it's not, look, Andromeda 2 is using, elements of this, and is going to extract data that we'll be interested to build further, maybe Andromeda 3, but do something that has some basis that at least looks at all 4, because I think that's, the future is certainly personalizing resuscitation, and that has something that's even personalized at a greater level without making the complexity so high that we necessarily have to be doing TAPC to PSP ratios on everyone, and et cetera, et cetera. So I think in terms of research, should be really interesting. We have the paper out. I'm sure it'll eventually come out, in whether it's this this edition of it or another. And then, I mean, as you mentioned earlier, we've really structured H&R this May to be, first looking at congestion for that sort of the next day. And then the second day being really looking at all these interfaces with matching workshops that, people can leave and have a good feeling. So, I really got the concepts down, and I have some tools to take home and play with. But anyways, again, none of these concepts are really new. It's just putting it together in a sort of systematized way, and realizing that the center of your resuscitation is the microcirculation, and that's what you got to tweak everything around it to try to improve it.
Yeah. Well, Phil, thanks so much for joining us. Eduardo, always a pleasure.
And thank you everyone for joining the HCP Rounds. Remember that we have a website, hcprounds.com, and we post all of these discussions online. And you can go and look at previous discussions we've had, and then, of course, don't miss the future ones. Thank you, Phil, for being here.
Thanks so much for having me, guys.